Hi everyone, and welcome to our module on hemoglobin. Hemoglobin is a very important component of red blood cells. It's what carries oxygen, and it's a complex structure made up of two important elements. The first element are the globin chains. These are polypeptides, and most hemoglobin molecules have four chains in two pairs. This is a representation of what hemoglobin might look like here, and you can see that there are two blue molecules here. Those are globin chains, and two red molecules here, so a total of four in two pairs. The second element of hemoglobin is heme. It's a molecule, it's not a peptide, and it's represented in this picture by these little green things here, and there are four of them inside the hemoglobin compound. There are four types of globin proteins, sometimes called hemoglobin chains. There are the alphas, the betas, the gammas, and the deltas, and they all have different functions in different molecules of hemoglobin. So when you put the different globin chains together, you make different hemoglobin types. And there are three types you should definitely know: hemoglobin A, hemoglobin A2, and hemoglobin F. So hemoglobin A is the main hemoglobin in adults. It's about 95% of adult hemoglobin. And it's made up of two alpha and two beta chains. And this is the bread and butter workhorse hemoglobin type in the adult human body. Second type in the adult is called A2. It's the less common type, and it's got two alpha chains and two delta chains. Another important type is found in the fetus. It's called hemoglobin F. It's the fetal type, and it has two alpha chains and two gamma chains. So let's talk about that fetal hemoglobin some more. That's hemoglobin F with two alpha chains and two gamma chains. After 8 weeks of development of the fetus, hemoglobin F is the predominant hemoglobin. It represents about 90% of fetal hemoglobin. The levels start to fall in the weeks or months after birth, but newborns still have a lot of fetal hemoglobin present. In adults, HbF is about less than 1% of total hemoglobin, so just a little bit remains behind. It has a higher oxygen affinity than the adult hemoglobin, hemoglobin A, and this is useful to the baby because it helps to transport oxygen from the maternal circulation. Remember, the baby needs to withdraw oxygen from the placenta into its own circulation, so having a hemoglobin with a higher affinity for oxygen helps to do that. There are a number of globin chain diseases, and I won't get into these in detail, but I'll just quickly review them here for you. Alpha thalassemia is when you have underproduction of the alpha chains. Beta thalassemia, minor or major, is when you have underproduction of the beta chains, and then sickle cell anemia is when you have an abnormal type of hemoglobin created called HbS. Now let's talk about that other component of hemoglobin, the heme molecule. So this is a molecule with iron in the middle. This is a picture of it over here, and here's the iron, the Fe, right in the middle. The ring around the iron is called a porphyrin ring, and patients who have porphyrias have defects in the enzymes that produce the porphyrin ring. And the oxygen that the red blood cells uptake is going to bind to the iron in the center of the heme molecule right here. There's a molecule called 2,3-bisphosphoglycerate. It's often just called 2,3-BPG, and this is found in red blood cells, and it promotes oxygen release from hemoglobin. There's always a little bit of it found in your red blood cells. If the levels of 2,3-BPG go up, this is going to decrease oxygen affinity for hemoglobin and make it easier to deliver oxygen to tissues. And one circumstance where this happens is at high altitude. So people who live high up in the mountains for a long time are chronically exposed to hypoxic conditions from the low pressure over there. Over time, the red blood cells will make more 2,3-BPG, and this will help the hemoglobin unload oxygen into the tissues. There's a tie-in with biochemistry involving 2,3-BPG, and that is because 2,3-BPG is synthesized from diverted 1,3-BPG, which is a glycolysis intermediate. Shown on the screen here are the last several steps of glycolysis, where glycerol 3-phosphate is converted into pyruvate. One of these steps involves synthesis of 1,3-bisphosphoglycerate, and red blood cells have an enzyme called BPG mutase, which can divert some of this 1,3-bisphosphoglycerate into 2,3-BPG. This is actually bad for the red cell because it sacrifices ATP from glycolysis. Pyruvate is normally used by red cells to make ATP. Recall that red cells do not have mitochondria, so they must use glycolysis for all their energy. However, sacrificing a little bit of the 1,3-BPG turns out to be a worthwhile investment because it allows the cell to function better as an oxygen carrier in certain settings. Hemoglobin can exist in two forms. There's one form called the taut form, or the T form, and this has a low oxygen affinity. This tends to release oxygen, and this is a form that's favored in the tissues. The tissues want oxygen to be released so they can pick it up and use it for metabolism. You can just remember the T stands for tissues. Then there's a relaxed form called the R form, which has a high oxygen affinity. This likes to hold onto oxygen, and this is the form that's favored in the lungs, where you want to pick up as much oxygen as possible from the air. In the tissues of the body, like in muscle, for example, you have a relatively low pH. This means you have a high concentration of hydrogen atoms. You also have a high concentration of CO2 in these tissues. And this is all going to favor the T form, and this is because you want oxygen released for use because metabolism is occurring in the tissues. In the lungs, you have the opposite conditions. You have a high pH. This means there's a low concentration of hydrogen atoms and a low concentration of carbon dioxide. This favors that R form, and this helps to bind oxygen to carry it to the tissues. Let's talk about a very important topic, which is the oxygen hemoglobin dissociation curve. So the first thing we need to discuss is how hemoglobin gets saturated with oxygen. So in this chart, I've put the concentration of oxygen, which is the PO2, on the x-axis, and I've put the percent saturation of hemoglobin on the y-axis. Now, if each molecule was just as likely to bind to hemoglobin as the next, what would happen is, as the concentration of oxygen went up, the hemoglobin saturation would steadily go up until it plateaued out at a maximum value. This is what myoglobin does. Myoglobin is related to hemoglobin. It's found in muscles, and myoglobin is just as likely to bind one molecule of oxygen as it is the next, and so it follows a curve like this. Hemoglobin is different. Hemoglobin starts to bind oxygen at one rate, and then it speeds up, and then it flattens out at an upper rate. It has an S-shaped curve. And the reason for the S-shaped curve is because the first molecule makes the second molecule more likely to bind, and it gives it a curved shape like an S, very different from myoglobin, in which there's no change in the likelihood of binding that second molecule compared to the first. The reason for that S-shaped is because of a phenomenon called cooperativity. The four heme groups in the hemoglobin molecule do not undergo simultaneous oxygenation. The first oxygen molecule that binds increases the affinity of hemoglobin for the second molecule, and it makes the S-shaped curve. In other words, oxygen molecules begin to bind at one rate at a relatively modest slope, and then the slope increases because of cooperativity, and then you start to reach the top and it starts to plateau out, and this gives it the S-shaped curve. Cooperativity is an example of an allosteric effect. An allosteric effect is a shape change of protein, and allosteric proteins can change their affinity for binding by changing shape when they get influenced by other smaller molecules. There are a number of allosteric proteins. Most of them are like hemoglobin. They're multi-subunit proteins all sort of stuck together. So hemoglobin is an allosteric structure, and cooperativity is called a positive allosteric effect. It means that binding of one molecule makes the next molecule more likely to bind. There are such things as negative allosteric effects, where binding of one molecule makes the next molecule less likely to bind. So oxygen is not the only allosteric effector of hemoglobin. There are other things which affect hemoglobin's likelihood of binding oxygen, and those are things like the pH, the temperature, the level of 2,3-BPG, and the carbon dioxide level. Changes in all four of these things change hemoglobin's likelihood of binding oxygen. So this gets us into a discussion of things that shift the hemoglobin-oxygen dissociation curve. And first we're going to talk about rightward shifts. So let's look at this picture down here. I've got the concentration of oxygen on the x-axis and the saturation of hemoglobin on the y-axis. The blue line is a normal hemoglobin-oxygen dissociation curve. The red line is a curve that's shifted to the right. When the curve shifts to the right, it's easier to release oxygen. And things that shift the curve to the right are higher levels of carbon dioxide, BPG, higher temperature, or higher concentrations of H+. And remember, higher H+ means a lower pH. So let's talk about the consequences of shifting to the right. Let's suppose we had a PO2 of 50. If we were on the normal blue curve, hemoglobin would be saturated right about here. That's close to 75%. But when we shift to the right at a PO2 of 50, hemoglobin is only about 50% saturated. So we have unloaded an extra 25% of oxygen by shifting to the right. This means it's easier to release oxygen. It means that more oxygen will get released. So all of these things cause hemoglobin to let go of oxygen and release more oxygen, and that's why they shift the curve to the right. Now let's talk about left curve shifts. These things make it harder to release oxygen, and things that shift the hemoglobin curve to the left are the opposite of the things that shift it to the right. So these are lower levels of carbon dioxide, BPG, temperature, or H+, and a lower H+ means a higher pH. And these things are all going to move the curve from the blue to the red line to the left. So once again, let's pick a level of, say, about 30 or so right here. If we were on the blue curve, that would correspond right here to a saturation of about 50. But when we shift left, we are all the way up here to a concentration of about 75. So by shifting to the curve left, we've caused hemoglobin to hold on to more oxygen. That means it's harder to release O2 when you shift the curve to the left. Let me just mention, by the way, that fetal hemoglobin, that HbF with 2 alpha and 2 gamma chains, is shifted to the left compared to normal hemoglobin, and that means that fetal hemoglobin has a higher O2 affinity, as we discussed before. Now let me talk about some molecules that interfere with hemoglobin's ability to bind and release oxygen, and the first one is carbon monoxide. Carbon monoxide binds to the iron in heme just like oxygen, but it does so at 240 times the affinity of oxygen. It's much more likely to bind those heme molecules than oxygen is, and when it binds, it's going to block O2 binding sites so that hemoglobin cannot absorb as much O2 as normal. In addition, it's an allosteric modifier of hemoglobin, so it's going to make the other binding sites less able to offload oxygen. This is going to shift the dissociation curve to the left. So this is a drawing of what that would look like. The blue is a normal curve. So first of all, the maximum carrying capacity of hemoglobin falls in the setting of carbon monoxide. It drops down here because carbon monoxide is blocking some of those sites for oxygen. In addition, it shifts the curve to the left here because carbon monoxide is an allosteric modifier of hemoglobin. So it creates a different shaped curve that is to the left and has a lower peak than normal. Patients who get carbon monoxide poisoning usually have nonspecific symptoms. Headache is one of the most common symptoms. They may be tired, they may be nauseous, they may be dizzy. There's a classic but very rare sign, which is cherry red lips. So carboxyhemoglobin, which is hemoglobin bound to carbon monoxide, is red, and so the patient will have bright red lips. You will not see the blue lips you would expect in a patient who might have trouble breathing from cyanosis. You can't use the standard pulse oximeter to measure the amount of carbon monoxide. It can't differentiate between carboxyhemoglobin and oxyhemoglobin, so it will show that the patient has normal saturation levels. To diagnose this, you have to send a special blood test called a carboxyhemoglobin level. Normal people have less than 3% carboxyhemoglobin in their blood. Smokers have a little bit higher percent, up to 10 to 15. And if it's greater than 15%, it suggests poisoning. And this is something you might diagnose in someone who's got those nonspecific symptoms and is living in an environment where they don't realize they're exposed to high levels of carbon monoxide. And the treatment is to give oxygen, which will eventually push all the carbon monoxide off of the binding sites over time. The next hemoglobin disorder I'm going to discuss is called methemoglobinemia. So in order to understand methemoglobinemia, you need to recall that iron in hemoglobin is normally present in a reduced Fe2+ state. But there are certain drugs which can oxidize iron to the Fe3+ state. And when Fe3+ is present in hemoglobin, we call that methemoglobin. And there's normally a very small amount of this present in your blood, usually less than 1% or so of all hemoglobin molecules. But when certain drugs are administered, they can increase that percentage to 10 or 20 or even 50 or 60%, and then patients can get very sick. The problem with high levels of methemoglobin in the blood is that Fe3+ cannot bind oxygen. In addition, it alters the remaining Fe2+ heme molecules so that they bind oxygen but cannot release it to tissues. In other words, it causes a leftward shift of the remaining Fe2+ iron molecules on the hemoglobin dissociation curve. This is a very bad combination. It essentially creates a functional anemia where patients either cannot bind oxygen to the 3+ molecules or cannot release it when it's bound to the 2+ molecules. There are several drugs that are common culprits for causing acquired methemoglobinemia, and one class of drugs are the local anesthetics. Drugs like benzocaine and lidocaine can do this. Another drug class that does this is nitric oxide. This is sometimes administered to premature babies in the intensive care unit, and they can develop an acquired methemoglobinemia. Also, dapsone, which is a rarely used antibiotic, has been known to cause methemoglobinemia. The treatment is a compound called methylene blue, which quickly reduces Fe3+ iron back to the Fe2+ state. So the classic clinical scenario to know for your boards is an endoscopy patient who has just had a camera inserted into the throat for diagnosis. Benzocaine spray is often used for throat analgesia. Post-procedure, if the patient gets methemoglobinemia, they will complain of shortness of breath. When methemoglobin is present in the blood, it gives it a chocolate brown color. So if there's a significant percentage of methemoglobin present, the blood draw will be described as showing chocolate brown blood. The oxygen saturation done by pulse oximetry is variable. The methemoglobin interferes with the pulse oximeter, so you can get values ranging anywhere from the 80s to the 90s. If you draw blood gas, the PaO2 will be normal. That's because there's a normal amount of oxygen in the blood. It just cannot be bound to the Fe3 plus methemoglobin, and the amount that is bound to the 2 plus cannot be released. So this is the classic scenario to know for your boards. An endoscopy patient, you should also know that this can happen to premature babies who are given nitric oxide for pulmonary vasodilation. Finally, I'll discuss cyanide poisoning. So cyanide binds to Fe3 plus in cells. This blocks the electron transport train in mitochondria. Aerobic metabolism stops, so these patients have functional hypoxia. Even though there's enough oxygen around, they can't use it because the electron transport chain is blocked. This is especially bad for the brain and the heart. Anaerobic metabolism occurs, lactic acidosis occurs, and as many of you may know, cyanide poisoning was used in concentration camp gas chambers in World War II. It's fatal when patients are exposed to large amounts. The reason I mentioned this in the hemoglobin video is because there's a component of treating cyanide poisoning that involves hemoglobin. Cyanide poisoning can be treated with nitrites like amyl nitrite and sodium nitrite. These compounds generate methemoglobin, which, as we have discussed, contains Fe3 plus iron, which binds the cyanide. This pulls cyanide away from mitochondria and allows some oxidative phosphorylation to begin while the cyanide is washed out of the body. Other treatments for cyanide poisoning I've listed on this slide. These include hydroxycobalamin. This is a precursor of vitamin B12, forming a compound called cyanocobalamin, which is readily excreted in the urine. And then finally, thiosulfate, which is sodium thiosulfate, is another treatment for cyanide poisoning. It transforms cyanide into thiocyanate, which is then renally excreted. And that concludes our module on hemoglobin.